All right, and now we move on to our last presentation of the last heat of the day. It's another presentation from AAP by Dr. William G. Lee, titled Sex-Based Disparities in the Management of Pediatric Gonadal Torsion. So let's see it.
Good morning. Thank you to the selection committee for the opportunity to present our work. I have no disclosures. Gonadal torsion commonly affects the adolescent population, where timely surgical intervention is critical in preserving long-term fertility. In an effort to standardize expedited care for testicular torsion, in June 2015, the U.S. News and World Report implemented a national quality metric encouraging children's hospitals to expedite patients with suspected testicular torsion to the OR in under 4 hours. This led to the introduction of expedited clinical pathways for testicular torsion and subsequently increased testicular salvage rates. However, despite the benefits observed in testicular torsion, national quality metrics for the expedited management of ovarian torsion are lacking. In addition, since the implementation of the national quality metric for testicular torsion, no prior studies have evaluated the trends in time to operative intervention for children with ovarian torsion. Thus, the objective of this study was to evaluate trends in time to OR both before and after national quality metric implementation for both male and female children with suspected gonadal torsion. We hypothesized that post-quality metric implementation, the time to OR would decrease in male children but remain unchanged for female children. To study this, we performed a single-center retrospective cohort study of children who presented with suspected gonadal torsion and underwent surgery during this time period. The primary outcome was defined as time from patient presentation to the medical center to patient entrance into the OR. Our secondary outcome was defined as gonadal detorsion without orchiectomy or oophorectomy. As the quality measure for testicular torsion was implemented in June of 2015, we evaluated trends in annual median time to OR by performing an interrupted time series analysis using June 2015 as the intervention time point. In addition, bivariate analysis of the ovarian torsion cohort was also performed to evaluate the potential impact of a known enlarged ovary greater than 5 centimeters at time of hospital intake on the primary and secondary outcomes of interest. We excluded patients who underwent surgery for any indication other than suspected gonadal torsion. Over the 9-year study period, 216 patients were included in the testicular torsion cohort, and 120 patients were included in the ovarian torsion cohort. In the testicular torsion cohort, median age was 13 years, with the majority of patients presenting with testicular pain and/or scrotal swelling. Post-quality metric implementation, we observed an increase in patients reporting symptoms of nausea and emesis, and a decrease in scrotal swelling, but there was otherwise no difference in patient demographic or clinical characteristics pre versus post-quality metric. In the ovarian torsion cohort, the median age was also 13 years, and the majority of patients presented with abdominal pain, nausea, and emesis, and there was also no difference in patient characteristics pre versus post-quality metric. For the testicular torsion cohort, overall median time to OR was fractured at 47 minutes. After implementation of the national quality metric for testicular torsion, in June of 2015, the interrupted time series analysis revealed a significant decrease in median year-to-year time to OR by 27.8 minutes per year. In addition, the variation in time to OR demonstrated by the interquartile range also decreased post-quality metric. For the ovarian torsion cohort, overall median time to OR was 462 minutes, and following quality metric implementation for testicular torsion, there was no significant change in time to OR. In addition, the variation in time to OR remained unchanged. Over the 9-year study period, we also evaluated the rates of gonadal salvage. In comparing patients who underwent gonadal salvage to those that did not, for testicular torsion, patients who avoided orchiectomy had a significantly shorter median time to OR. However, for ovarian torsion, we did not observe a significant difference in time to OR between patients who underwent oophorectomy and those that did not. Lastly, bivariate analysis of the ovarian torsion cohort was also performed to compare patients with a known pre-hospital enlarged ovary to those without. Patients with a known enlarged ovary were found to experience a shorter median time to OR, but this ultimately did not affect rates of ovarian salvage. In summary, following implementation of a national quality metric to expedite surgical care in testicular torsion, we observed a significant decrease in time to OR for patients with suspected testicular torsion. However, patients with suspected ovarian torsion did not experience similar expedited surgical care. We also found that a shorter time to OR was associated with the female patients with a known enlarged ovary, which consisted of 52% of our female cohort. However, there was no significant association between time to OR and ovarian salvage, which may be confounded by an overall trend toward ovary-sparing surgery during this time period at our institution. In conclusion, this study highlights the benefit of a national quality metric in expediting surgical care in gonadal torsion, as well as the sex-based disparity in the urgent surgical treatment of female children presenting with suspected gonadal torsion. As we work towards a national quality metric for ovarian torsion, prospective longitudinal studies on patients with ovarian torsion are needed to further elucidate the effect of symptom duration and expedite surgical care on long-term metrics of fertility, such as successful pregnancy and line birth rates. However, we feel that we can do better for our patients with ovarian torsion by implementing QI initiatives which may expedite the referral, evaluation, imaging, and surgical care pathways, especially in patients with a known history of an enlarged ovary. I'd like to thank my mentor and project PI, Dr. Lorraine Kelly Kwan, for her guidance with this project. Thank you very much, and be happy to take any questions.
Awesome. Amazing study.
I actually have a couple quick questions. Number one, in this study, were the surgeons who did the testicles urologists and the surgeons who did the ovary pediatric general surgeons, or were they the same cohort of surgeons?
Yeah, thanks so much for that clarifying question. Yes, you're absolutely correct. The ones who did the testicular torsions were pediatric urologists, and then pediatric surgeons did the ovarian torsion.
Different surgeons, different criteria of how they do things in their literature. The second question is, would you, in general, is testicular torsion more easily diagnosed than ovarian torsion?
Yeah, that's one of the main discrepancies that's described in the literature between ovarian torsion and testicular torsion. It's difficult to compare them apples to apples because they are very different as far as their diagnostic and evaluation and management. Males, they often present earlier due to the external site of the gonad. They're imaged and expedited to the OR quickly or more rapidly compared to ovarian torsion as well. That's well described in the literature. And ovarian torsion, as when we see these consults, the symptoms are often non-specific. Abdominal pain, nausea, and emesis were the most common in this study, and the internal location of the ovary also has diagnostic overlap with alternative intra-abdominal pathologies that are more common, such as appendicitis. And then the process of imaging and the sensitivity of imaging is also different as well. The sensitivity for ovarian torsion for absent flow is anywhere from 40 to 73%. And then for a negative or a positive read, meaning concerning for ovarian torsion or cannot exclude, the sensitivity is only 51%.
Right.
And so comparing the two directly is I don't think appropriate, but I think that what we can learn from this study is that implementing quality metrics to help improve care overall has worked for testicular torsion, and something we can learn from to improve the care of our female patients.
We just have to make sure the problem with ovarian torsion is we have to find that balance, because we looked at a couple of the negative laparoscopy rate's very high because you can't rule it out. So we go in and we look all the time, and we have a very, very high negative rate across the country. So we have to figure out how to do better for the ovaries without over-indexing on the aggressive surgery side either. So it's a great study. It's very provocative, and it points out a lot of ways we could do better. So thanks for presenting that.
Yeah, thank you very much for the opportunity.